This is Marcy Ravitch. I'm the director of the Massachusetts Child Psychiatry Access Project, and we want to welcome you to our October clinical conversation, which we're calling Consults for the Field. The idea for this webinar actually came from one of our participants in our last webinar. So when you get your survey after the webinar, be sure to complete it and give us your ideas for future topics. So, as you know, our clinical conversations take place the fourth Tuesday of each month from 12:15 to 1:15. A few housekeeping issues. First and foremost, we have changed platforms for our webinar to WebEx. And so please forgive any brief difficulties we might experience. We're trying to get everyone used to this. So also, for your information, there is a chat function, so you'd be able to click on that, make sure you're addressing your chat to either everyone or to me, and we'll use that for taking questions, or you can raise your hand, but we prefer the chat if possible. And we will end at the end of the two consults that we're going to present today. This presentation will be archived on our website at www.mcpap.org under About McPap, and also under Archive News and Webinars. Briefly, you will receive a survey following the presentation sometime later today that will come from our program management specialist, Mary Houghton. A little different than the ones you received after previous webinars because of the change in platform. So I think we are ready to get started. If you have any technical questions, just address it to the chat box and we'll try to help you. So I think I'll introduce, are you on yet? I'm not sure. I don't think so. I think we're, Dr. Zagul and Dr. Gottsagen, I think we'll start with you. So let me introduce Dr. Shadi Zagul, who is a child and adolescent psychiatrist who works at our MCPAP Bay State team. So if you're from the West, you may know Dr. Zagul. He finished his internal medicine and psychiatry residency at the University of Connecticut Health Center. He completed his advanced psychiatric training in 2008 from Children's Hospital in Boston. Dr. Zagul, or Dr. Z as he likes to be called by his young patients, enjoys spending time with his family and playing the guitar. Dr. David Gottsagen, who is our primary care provider conversant today with Dr. Zagul, is board certified by the American Board of Pediatrics and a member of the American Academy of Pediatrics. He is a clinical instructor in pediatrics at Bay State Medical Center and an adjunct staff member at Boston Children's Hospital. Sagan is a certified consultant in clinical hypnosis under the auspices of the American Society of Clinical Hypnosis and is also a member of the American Board of Medical Hypnosis. He believes in helping young people access their inner strengths and use natural methods of healing whenever safe and effective. Oh, okay. So I am going to unmute Gottsagen and Dr. Zagul in.
Okay.
And then when you're done, then we'll move on to Dr. Reardon's case.
Okay. Well, I should. Hi, Shadi. Thanks for that nice introduction. I believe I'm scheduled to start by presenting the case. And it's of a young man who is now 7 years old, who I've seen all life, along with his now 3 siblings, a really delightful and complicated family whose I first got to know when one of the older sisters was hospitalized with asthma. All have asthma, they all have allergies, they all have eczema, and our little guy was a normal, was born by C-section and did well in infancy until about the age of 7 months. I should say that he did, except he started to develop ear infections and infantile eczema. And at 6 months, I referred him to early intervention because at that time he had some delays in motor development. He was seen by intervention and then was noted to, around a year of age, to begin to have troubles with sleep and self-aggressive behavior. He'd actually had a few tantrums in which he'd give himself bloody noses. Then, around the age of 18 months, his little brother was born, and he then began to, he actually stopped speaking. It was quite dramatic, and because of language delays, early intervention began to focus on that. He was very irritable. He'd have really violent tantrums and had other problems with mood regulation. So he continued to have a lot of problems. He got P tubes right around 15 months. His hearing was checked and it was fine. He was seen for asthma and continued to be seen for eczema, and was actually seen because of his nosebleeds by his otolaryngologist. Then around the age of 2, because he was having a lot of troubles with social interactions now and not making adequate progress with his development, I referred him to Susan McQuiston, a neuropsychologist. And when she saw him, this was just shy of age 3, so he's about to age out of early intervention, unfortunately. She found that he was difficult to assess because he'd have random bouts of tantrums in the session. She confirmed what I had found in office, that he failed elements of MCHAT that involved pointing objects or going towards objects when his parents pointed towards them. And according to what she could do of the Bailey scales of infant development, infant and toddler development, and looking at the MCHAT and the CBCL, she found that he had global delays and diagnosed him with PDD, NOS, as a mood disorder. So at this point, I referred him to MCPAP. He was one of the most difficult kids, and I said, I really like this family. I was seeing his 2 older sisters, and now his baby brother. His Mark's as a medical assistant in a doctor's office. And Dad, while the family is together and he's a very fellow from what I understand, I've never met him and doesn't seem to be very involved in civics or discipline. So I guess just hand it over to Dr. Segul, who will take over from his with this.
Yeah.
Okay. Did I leave anything out with the presentation at the point I sent them to you?
No, I think that's a great summary.
Yeah.
That's a great summary, and I'm probably going to repeat some of the things Dr. Gottsagen said and maybe just elaborate a little bit on some of his symptoms. So again, I saw him at age 2 years, 5 months at that time, and he can actually his early intervention worker who she was really concerned about him, in addition to the mom, of course, and she corroborated the history, and I'm going to her again in a minute, but So his symptoms were really, really severe. His head banging, his thrashing. He would rub his face and bang his head so hard that he would bleed from his nose. And his mom actually showed me a picture. I still remember it very vividly. His face being all bloody. Those tantrums could have lasted 2 hours. They started around 9 months at that point from mom's description, between 6 and 9 months. Precipitants to those were overstimulation, bedtime, transitions, disappointments. And he had a lot of difficulty with sleep, and he would wake up at 3 a.m. Distraught and crying, and it would be extremely difficult to soothe. So Dr. Gottsagen mentioned about the developmental delays, gestational diabetes in the mom and preeclampsia and C-section. The psychological testing was reviewed again by Dr. Gottsagen here, as well as the asthma and the eczema. He had allergies. There was very strong family history of autism, bipolar disorder, and suicide. Not first-degree relatives, like meaning mom and dad and siblings. However, close maternal relatives, maternal grandmother and great-grandmother. There was a very strong history of mood disorders. And importantly, there was no history of trauma or abuse, which the early intervention worker who has been working with the family for a long time definitely voiced no concerns about that, which was very helpful. So I saw him. You see this very adorable boy, and he has these he had long hair already with dreadlocks, and really adorable young boy. He wasn't dysmorphic. He was very pleasant and quiet and shy in the first evaluation I saw him at the MCPAP. He had no stereotypies, no abnormal involuntary movements. He had definite reciprocity and looked at this examiner cautiously. He, would smile very shyly. He also played imaginatively with a bus that he drove around the office. Unfortunately, he was nonverbal. I couldn't get any words from him. He was able to tolerate about an hour in the interview, which was completely different from the description that Dr. McQuiston gave when she saw him just a few weeks earlier. He would sit on the worker's lap, and however, it was really hard to assess more in terms of his mental state. At that time, I really thought he diagnostically was still very challenging, and he had the severe temper and mood dysregulation. He had the developmental delays and communication delays, as well as the diagnosis of autism spectrum, back then called PDD, not otherwise specified. He definitely had some symptoms of that. But again, when you look at him in the way he reciprocated, also me a little, it wasn't as clear, let's say. It wasn't as typical and in kids with autism. So I thought, he definitely has the frustration related to his communication inabilities and inability to verbalize his needs as well as other kids his age. Of course, autism with irritability was the other differential diagnosis. ADHD, he was really not hyperactive on mental status, and there was no clear report of that. It was more the withdrawal, if you will. I thought maybe he has an undiagnosed physical ailment that's really making him angry and upset because he can't verbalize it. Could have been his teeth were hurting, or he has some kind of a cavity or GERD that wasn't diagnosed, or abdominal pain. Additionally, the severe mood dysregulation or an evolving mood disorder, again, it's a very difficult diagnosis to make at this age, and largely deferred the diagnosis. So this was clearly an outlier in terms of presentation, definitely more severe than other kids that we have seen. It seemed like a desperate family situation. I mean, the family was sleepless. They can't go out in public with this kid. He's hitting other kids on the head, and his 1-year-old brother was being hurt by this kid. They reported trauma, and he had the supports at home, and it was a loving family, caring family. And in spite of lack of evidence, if you will, you're presented with this situation, and you really feel you need to make some kind of intervention or recommendation in addition to all the support that he's already getting. So I recommend to Dr. Gottsagen start on a very low dose of guanfacine or 10x at 0.25 milligrams twice a day. Dr. Gottsagen did start for a few weeks with an increase to 0.5 milligrams twice a day. However, unfortunately, he had no response, and in fact, Mom noticed that he has worsening of his tantrums. He's more angry, and that was discontinued. This is the summary of what happened during our initial interaction with the patient, and Dr. Gottsagen's intervention after that evaluation. So, due to failure of this recommendation, after considering, we decided to really transfer the patient to psychiatric care due to, again, his young age, severity of symptoms. And I started seeing him, and eventually I did give him a low dose of risperidone. He partly responded to. He had some improvement in his communication after joining the school and continued the early intervention and getting an individualized educational plan. Had, I think, maybe one short period of in-home supports. However, due to my mother's work and scheduling, and that didn't continue for a long time. Mom tapered the risperidone. In 2016, he was sick by then. I decided to, due to his severe anxiety, to initiate a fluoxetine, which he really responded beautifully to. And he's shown a lot of more interaction with other children, which before he was extremely isolated in the school setting, and improved communication dramatically, was able to participate a little bit more, and he's definitely brighter and less anxious when I would see him. And that, in summary, the case. And I think the take-home message is here is that the differential diagnosis in very young children with severe dysregulation like this is really broad. And initially, it is very difficult to ascertain. It's important to consider undiagnosed ailments in children who are nonverbal and can't communicate. Trauma abuse is another thing that is necessary to rule out in children this young, although like the early intervention worker and the fact that it was a loving family didn't point to that as being the reason for his dysregulation. I think the anxiety was the main driver for the patient's behaviors. And we know that anxiety continues to be one of the main and most common causes of severe irritability in children. It's usually time and longitudinal follow-up, clarify diagnosis, hopefully. Psychopharmacological interventions are really, the studies are really lacking on this very young population. And most of the research is really on more on older kids. There are multiple classes of medications that are studied in this a little older population, say 5 and older. It was really a difficult decision to initiate psychopharmacological intervention in such a young age. But I think it was warranted at that point. I think those are some of my take-home messages. And I appreciate your listening, and I don't know if there is more I should add, or is there enough of a presentation?
I just wanted to point out. Okay. I just wanted to point out that it's a really good point about medical issues. His eczema was under better control by the time he saw Dr. Segul. He was on Zorcon, seeing a dermatologist, so that was under control, and so was his asthma. He's on Pulmicort, and he really didn't seem to have an undiagnosed medical problem. And anxiety was part of his presentation. Right along, Susan McQuiston noted it on his last checkup, where he gets really upset when he sees his brother ice skating. Now, I told him he had a lifesaver with him, and you mentioned hypnosis. The extent of what he did hypnotically was, I said, you could have a duel with his saver, with his worry, and he'd win that duel. So maybe that he can get him on the ice skating with his brother. But I just wanted to throw that in. There were no medical issues that be causing the mood dysregulation directly.
Thank you, Dr. Segul and Dr. Gottsagen. If you have questions for them about this case specifically, please type them into the chat box, and we're going to move on to Dr. Michelle Reardon, who will be presenting our next case, and we will hear from her, and then we will take all questions at the end. So, Dr. Reardon was with us a couple months ago, so you may remember her. She received her medical degree from Pennsylvania State University College of Medicine. Dr. Reardon completed her residency in pediatrics and psychiatry and child psychiatry at Brown University. She is boarded and triple certified. And she previously worked as the training director at the adolescent unit at Kearney Hospital in Dorchester for 3 years. And currently she is the medical director for the partial hospital program at North Shore Medical Center and the medical director of our MCPAP team at North Shore Medical Center as well. So, Dr. Reardon.
Thank you much, Marcy. I appreciate it.
I'm going to pull up your slides right now. Okay.
All right, the case that I'm going to be presenting today is a young man that I saw here at MCPAP who's referred to us because of school phobia. He's a pretty complex kid. Part of the reason why I thought he'd be a good case to present, and a very common cause or reason why we see kids here at MCPAP. So he was 16, and his issue was he was refusing to go to school, and we asked to see him for a face-to-face evaluation. So came in complaining, long history of problems with attention, focus, concentration, and feeling like he struggled in school and had to really work to keep his grades up. Felt like particularly he struggled more with LA, English and language. Even when he worked really hard in English and language, he would oftentimes not be able to get above what he said was average grades, usually C. He also endorsed symptoms of panic and social phobia, and said that when he was in school with other kids, he would feel he would feel like other kids were talking about him and worried about other kids and what their thoughts were about him. He'd be in the classroom and oftentimes have to leave. This got worse after he sustained a concussion about a year prior to him seeing us. He had depression and felt like the depression had started about a year ago, again, shortly after the concussion, and had gotten worse over the past several months. He started to use alcohol and cannabis, try to help with some of the depression and anxiety, in particular the anxiety and the social phobia. Stopped the cannabis, but was still using a lot of alcohol and binging a lot of alcohol, especially when he was around his peers to help with that social phobia. He had a very, very significant family history, lots of ADHD, lots of learning disabilities, lots of OCD, and lots of alcohol. He had been started on Zoloft about 3 months prior for migraines from a neurologist that he'd seen following his concussion, but and did note some improvement with the social phobia while on this medication, but still felt like he was struggling with lots of symptoms of depression, as well as some significant obsessive fears. He's very, very bright. He had a verbal IQ of almost 130 and a full score IQ of 112, but had some lower working memory and processing speed, and showed deficits in executive functioning. You want to try, Marcy?
The next one is the takeaways.
So we saw him, and as well as endorsing the attentional issues, young man also endorsed some significant, as I said, phobia. He had felt like his anxiety had gotten better with the Zoloft, but was still feeling like the social phobia was bad enough that he was using alcohol. And he felt like the depression was really bad, and he was feeling really sad. And the depression had dated back to middle school for him when he had had a bad depressive episode in 7th grade. I felt like it got better and then returned again for him, and had worsened over the past year. Hadn't had any suicide attempts, but had some passive suicidality at times with his depression, and had made some statements when he had been angry and mad about wishing he was dead and hating his life. He noted that he felt like at times he was being watched and heard his name being called when he was depressed. And other times he felt like he could hear music when he felt really, really anxious. No other history of any other psychosis, delusions, paranoid behavior associated with any of this, and he died any mania and any history of any tics or other symptoms. Had been a child who had been pretty somatic. Mom had said he had refused foods as a young child. He had complained of stomach aches, particularly in young grade school, and more recently had been complained about GI problems and had been missing school because of some of the GI problems and headaches. His past medical history was significant for developmental delays of some speech through grade school, and he actually received speech therapy for his disarticulation issues. Concussion that he had sustained about a year and a half prior was during a football game. Felt like his concentration had both worsened, as well as his anxiety and panic. His headaches had been getting better since he had started the Zoloft and since he had seen the neurologist. Currently, he was treated with about 75 milligrams of Zoloft a day, but hadn't been tried on anything higher and hadn't tried any other medication. He was also getting some Inderal as needed for panic, about 40 milligrams, but feeling like that was not helpful when he had his panic attacks. He had missed a pretty significant amount of school. He was in 11th grade. He had not been held back in any classes, but he was taking 9th and 10th grade English classes because he'd failed those classes. No history of any testing from the school, no special education services from the school. Truant or struggling with school phobia over the past 2 years, and this past year had missed more than a month of school in the previous year. A CRA had been filed by mom last January because of his school phobia, and there was no history of any trauma or domestic violence. And as stated above, he's been struggling particularly with the alcohol, but no denied any other drugs. Had stopped using cannabis in the springtime. In the springtime, and I saw him in late summertime. He was drinking. The time I saw him, he was drinking about two to three drinks of hard liquor, usually on the weekends. He denied any blackouts or consequences, but mom said she had found empty bottles in the closet and was concerned about his drinking. And he stated that he was drinking to help with his anxiety and the feelings of awkwardness felt around other people. The history was significant for mom with ADHD, learning disabilities, and depression. She also had a history of panic attacks. She was on Prozac, and she had a positive response. She had 2 years of college and a nursing degree. A sister with ADHD who was 18, treated with Concerta in the past and currently on Prozac with a positive response, going to school at North Shore Community College. I'm a grandmother with OCD, anxiety, and learning disabilities. I'm a cousin with learning disabilities, intellectual disabilities, and cerebral palsy, seizure disorders. A grandmother with mood disorder, a question of whether or not it's bipolar disorder or depression. I have a history of alcoholism, ADHD, who received his bachelor's degree as an architect, and a paternal grandfather with a history of alcoholism. His CAPS, the CAPS is our screening that we do, was positive for moderate anxiety and panic, moderate to severe ADHD, mild to moderate depression, and moderate learning disabilities. So our diagnosis, when we saw him at the time, was ADHD and attentive type, social phobia, depression, moderate, and alcohol, and a history of cannabis use disorder. We amended to the primary care physician and pediatrician that because he had a partial response to the Zoloft, that he increased the Zoloft to 150 milligrams a day, 25 milligram increments, to try to better target some of the anxiety he was still struggling with and the depression he was still struggling with. We recommended that he had started on long-acting stimulant for his ADHD. Recommendations included options of Concerta, Metadate, Focalin, or Dexedrine. And we recommended that he stop the Inderal as we felt like it wasn't helping him, and instead start some clonidine because he was having some problems with his sleep and initiating sleep, 0.1 to 0.2 milligrams at bedtime. Ultimately, we also recommend that they could use Capve, 0.1 to 0.2 milligrams as needed during the day, or divided BD to help with the anxiety and sleep. We suggest he be referred for neuropsychiatry and neuropsychiatric testing to document not only the ADHD, but also to look more closely at the question of the specific learning disability, and also to assess his mood and give some ideas with projective testing. And we actually referred him to our partial program because we felt like he was struggling significantly enough that he could benefit from the increased structure and support and help with his school phobia and avoidancy. And he attended our partial program for about 2 weeks and did well in our partial program. I think our key points to this case, number one would be that morbidity in child psychiatry tends to be the rule. So most kids don't come to us with just one thing. They oftentimes have overlapping issues that they're struggling with. So as in this case, there were multiple things that brought this kid here and contributed to his school phobia. It wasn't just ADHD. It wasn't just his social anxiety. It wasn't just his depression, but it was a combination of all those things. So really important to screen for all those. It's also important to screen for some of the overlapping medical and neurological conditions. In this kid's case, he had a concussion that had made a lot of the primary anxiety and ADHD worse for him and made his school phobia worse for him. So again, making sure you get some good history as far as some of that stuff as well is really helpful. Family history is really helpful for us as well too, not only in helping us get at the diagnosis, but also in guiding treatment. So knowing that mom had on Prozac and Prozac had worked well for her helps us in that determination for kids, because there is a genetic response to medications for many of our kids, and kids are more likely to respond to medications that other families respond to. And the last point I would just make is don't assume because kids are really bright and have high IQs that they can't have other learning disabilities or ADHD. IQs and ADHD and learning disabilities are very separate things and very separate entities. And it's really important that when kids are struggling in school to make sure that you really screen and take a look at those and don't say because a kid is smart that they don't assume because a kid is smart that they automatically can't have other stuff going on.
Great. Thank you very much, Dr. Reardon. I'm going to go to questions. So I'm going to unmute Dr. Zagul and also Dr. Gatsagan. Looks like I was unmuted. Okay. And Dr. Godsagan. And we do have one question that came in through our chat that asks, this is for Dr. Zagul and Dr. Godsagan. Did Zahir have a medical workup? Sorry if I missed it. Hearing screen, chromosomal microarray, and Fragile X. What to do any brain imaging in nonverbal children who may be ASD but not diagnosed?
You want to take that, Dave, or whatever?
I could start. Yeah, he had received tubes and he received audiologic screening at the otolaryngologist. That's an excellent question, of course, for someone with recessive and expressive language problems. And no, I didn't. I didn't think showing signs of Fragile X, and I didn't do any brain imaging. Usually not for kids with developmental delays unless there's some sign of a syndrome or another neurologic problem, and take that.
Yeah, and I agree. I mean, unless there are some localizing symptoms or a history of seizure disorder, she did not have, then I usually defer any neuroimaging or MRI or CT scan. For genetic testing, I think that's a great idea. Although he does not show signs of Fragile X, but I think genetic testing is another thing that we can consider in terms of his workup. I do have to say he has improved, and maybe that's something we'll do in the future.
So I actually have a question. I'm wondering with this young child, at what point, Dr. Godsagan, did you feel like it became too much for you to manage, or what point did you decide to call back to MCPAP and ask for more help, and how did that transition go?
Well, he was youngest. I thought this was a really interesting case because I pretty early found out he was too much for me to handle. And for me, I never consider it in these situations me. I'm always feel like part of a team. There was an excellent early intervention team involved, preschool, and then Dr. McQuiston got involved. I mean, but at 2.5, I thought that we really needed to have a child psychiatrist's opinion. So that was the age, and really the earliest referral I ever made to MCPAP. So, Jim?
Thank you.
Yeah.
I have a question for you, Dr. Reardon, also. I'm wondering, in the course of your treatment with the young that you described, how did the primary care provider feel about managing him with all of his issues, and at what point did he feel a psychiatrist in the community was needed or not?
Well, so I think that's a good question, because a lot of these kids who are so complex, oftentimes I do think they get a little overwhelming for a lot of our PCPs to be able to manage, especially when they're struggling with issues like school phobia, because that's a big one, and that's a hard one for PCPs to be able to deal and manage with. I think this was one that the particular PCP did refer, because he had tried to manage some of this and was feeling overwhelmed and feeling like he needed more help and needed more resources, and that this kid and family needed more resources, and that it was in over his head, so to speak, and he was reaching out to us to kind of access some of that help and some of the psychiatric care that this kid hadn't been able to get prior.
So we're going to open this up not just for questions about these two cases, but if you have a case you'd like to inquire about confidentially, please, that would be of interest in terms of a broader learning for everyone. Feel free to raise your hand and I'll unmute you. In time, I'm wondering if you could talk about, I'm going to push you a little further, Dr. Reardon. So when the young man came out of the partial hospital program, was his PCP involved, or was he already in treatment with the psychiatrist? And how did that trajectory go? And how's he doing now?
When a partial, the PCP is always involved. So the PCP always gets involved, or is kept in the loop as part of that process. So of course the PCP is part of that process. Referrals were made for him for psychiatric care. He had just recently finished our program. I don't know if he followed up yet with the psychiatrist, but so I can't really answer. But he was doing well, and he had been able to transition back to school with the program, and had been able to get back to school with the treatment he received there.
Thanks. Wonderful. And similarly, I'm wondering, Dr. Gottsagen and Dr. Zagul, how is how's Zahir doing now?
And I think he's doing much better right now. He flourished after going to school and receiving some individualized educational plan and speech therapy and communication help. He's able to talk to me now when he comes into the office, and he's very playful, very pleasant. And additionally, like you said, he did start on the fluoxetine, which really helped him, again, with social interactions with other children. He's not as isolated, tolerating things more. His mom, actually, when I see his mom, she very much more relaxed, and when I started seeing her, and I think that's a big indicator that the family's affect not just the child's, in of treatment success. And I find that always to be a helpful clue when assessing response or response for that matter. So, yeah, he's doing much better. I mean, he's still cognitively delayed. He probably is a couple of years behind. But generally, I think he is very stabilized.
Thank you.
He gets math help, OT in school, speech.
Right.
But he's involved in karate. He has friends in school. His dad still doesn't get involved in disciplining him, but he's doing better. I described the intervention I made around anxiety. I think he was between therapists. Some way as a PCB, I can stay involved doing some behavioral counseling and coming up with his anxiety and sleep issues as well.
And I can just also add it is really a collaborative thing between myself and Dr. Gotzig. And even when we would talk about a different case, I still in like every few months, if we talk, that I would say, how is he doing? And he would ask me how he's doing. So it's a constant conversation, even though I might be seeing him in a psychiatric setting, but still there's updates that are going on. And I ask about his family. Dr. Gottsagen tells me about his mother, and who has also now developmental delays, if I'm not mistaken. So that's the other part of that I can also say here. So
Terrific. Thank you. I do not see any other questions at this time. I want to thank our presenters again, particularly our primary care provider, Dr. Gottsagen, for joining us and providing that perspective, which is exactly what we want to share with our other PCPs listening in. So thanks for joining us. Thanks to everyone for joining us. Again, I want to remind you that this session will be recorded and available on the MCPAP website, and that you will receive a survey later today. We really encourage you to take the probably 2 minutes that it will take to let us know how you're doing and give us any additional ideas for topics you'd like to hear about. Next conversation will be in November, and we will send an invitation to that as well. On your survey, if you have any problems with the WebEx platform, if you let us know that, we would really appreciate it, whether it was audio, video, registering, logging in, anything. If you could provide some feedback on that, we would greatly appreciate that as well. Thanks, everyone, and have a great day.
Marcy.
Thank you.